Assalamu alaikum. Today's topic, which I will discuss, is anemia in pregnancy according to the SOGP guideline overview. This presentation outlines the SOGP, that is Society of Obstetricians and Gynecologists of Pakistan guideline for managing anemia in pregnancy, a critical aspect of maternal and fetal health. The global burden of anemia in pregnancy. Anemia impact an alarming 42% of pregnancy women globally, with iron deficiency accounting for approximately half of these cases. In South Asia, the prevalence of the iron deficiency anemia can reach up to 65% among expectant mother, highlighting a severe public health crisis in the region. Pakistan alone is reported at the strategic 30 to 60% prevalence of anemia in pregnant women, underscoring the urgent need for effective intervention strategies. Defining anemia in pregnancy according to the SOGP and WHO guidelines, first and third trimester hemoglobin levels should be below. If the hemoglobin is below 11, are indicated of anemia, that is 11 gram per deciliter. Second trimester, a slightly lower threshold of 10.5 grams per deciliter is usually due to physiological hemodilution. Screening protocol initial screening is recommended at the first prenatal visit. As a patient is coming in the clinic for an antenatal checkup, it is the first test to be done and repeatedly be done after in each trimester as to know whether this patient is getting anemic or not. Why screening for anemia is early? Early detection will make management easier, as you all know, and it has both adverse outcomes on mother as well as fetus. Maternal risks include profound fatigue, increased susceptibility of infection, poor tolerance to postpartum blood loss. Fetal risks include low birth weight, prematurity, increased risk of perinatal mortality. Oral iron therapy can serve as both a diagnostic tool and an effective treatment in early stages. Etiology and risk factors of the pregnancy. Increased iron demand. The physiological demand of the pregnancy sufficiently increase in body's need for iron. Hemoglobinopathies, genetic disorders affecting hemoglobin production such as thalassemia can lead to anemia. Nutritional deficiencies, inadequate dietary intake, iron and other essential nutrients contribute significantly to anemia. Infections, chronic and recurrent infections can impair iron absorption and utilization, exacerbating anemia. Additional risk factors include multiparity, low socioeconomic status, and parasitic infections, all of which contributes to multifactorial nature of an anemia in pregnancy. How to diagnose? The first step is to do complete blood count, which should be done at the time of initial booking, and hemoglobin should be checked. Then if the hemoglobin level alters, you will go for serum ferritin test. It should not be less than 15 microgram per liter. It confirms the iron deficiency, while less than 30 is suggestive, and there should be plan of the treatment to be done accordingly. And inflammation consideration, interpret ferritin levels cautionally in the presence of inflammation or infection. Report testing. If no improvement in hemoglobin after 2 weeks of an oral iron, reevaluate and consider further diagnostic steps. Management strategy. Oral iron is the first line of the treatment. Oral supplements initially should be started. Recommended dose is 60 to 120 milligram of elemental iron daily. Dietary counseling is must. Patient should be educated on an iron-rich foods and which includes green leafy vegetables, and the factors that enhance the absorption of iron is basically vitamin C, or inhibits which inhibit the absorption includes tea, coffee. Monitoring should be done regularly. When to use parenteral iron or other interventions? IV iron should be started if the patient is intolerant of an oral drug and late pregnancy with insufficient time, that is the patient in her third trimester, and there is less time left for the delivery is to be done, so iron IV should be given. Severe anemia required rapid correction, as you all know. And then blood transfusion is the last resort, in which there is a life threatening condition and god forbid acute hemorrhage can happen, and so then you have to transfuse the blood to the patient, where we have to rapidly build in the volume of the hemoglobin, and it should be replaced correctly. Clinical outcome and follow up. Active labor management. Implement active management of the third stage of labor to minimize postpartum blood loss. Repeat hemoglobin assessment. Re-evaluate hemoglobin levels in the third trimester and during the postpartum period to ensure recovery. Further pregnancy prevention. Educate women on a strategy to prevent anemia in subsequent pregnancies, promoting long-term maternal health. Conclusion. Routine screening is the key. Prioritize anemia screening at the first prenatal visits as the fundamental step. Approach should be multidisciplinary. Healthcare providers must collaborate and helps the patients in the patient's education to optimize better outcome. Early evidence of the base therapy, timely and appropriate iron therapies should be given. Reduce the burden. Together we can alleviate the high burdens of anemia and pregnancy in Pakistan globally. Thank you for watching.